गिरीश पिक्चर రావట్లేదు. Okay, good morning students. Sorry for delaying the class by half an hour. It was inevitable for me. So how many of you have entered the class? Okay, so today I shall be talking to you on the topic of transplantation, which I presume it is not very important for you. But since you people have asked for the topic discussion in the class, so uh, with the consent of our HOD, I've brought up the topic here. So in this class, I shall be talking to you about the very basics of transplantation and a little bit of renal and hepatic liver transplantations. Okay. So you'll have to bear with me for maybe an hour and 15 minutes. So and we'll finish up the class by then. Okay. So with this class, first of all, you'll have to refresh. It is almost like refreshing your immunology. So you'll have to appreciate the immunological basis of transplantation and transplant rejection. That is graft rejection. You should also know about the immunosuppressive therapy that we advocate during transplantation, and some major concerns regarding organ donation. Okay. Also, the indications for transplantation. Why should we go for a transplantation in a particular patient? And a little bit of the surgical principles of organ implantation or organ transplantation. Then the likely outcomes after transplantation and a little bit of future developments. So this is what we're going to talk in the class today. First, to start with, make the topic interesting, we have to go with the history. So the very first idea of transplantation was around 300 AD when the Christian Arab saints named Cosmas and Damian were reputed to have successfully transplanted the leg of a patient with that from a deceased one who had died several days earlier. So this leg was replaced with the transplanted leg. Of course, whether or not it was successful is secondary, but the very attempt was done at such an early age. And the modern era of transplantation actually began in the 1950s after the development of anastomosing techniques of the blood vessels, which started at the beginning of 20th century. And the first successful kidney transplant was a living donor transplant. It was performed between identical twins in 1954 at the Birmingham Hospital in Boston with Joseph Murray and his colleagues. So these were the two identical sisters where the kidney transplant was performed, and they are seen with their children. Okay. Next, the very important milestone in the transplantation history was the discovery of immunosuppressants, namely the 6-mercaptopurine and its main compound is a thioprin. Okay, that was in 1959 by Schwartz and Dunchik. They had discovered the immunosuppressive properties of this agent in a canine kidney transplant. Next, the cyclosporin era began in the late 1970s, following by its discovery. And with the help of this discovery, they were able to achieve successful transplantations. That is, the transplant rejections rates and failure rates got decreased. So these first, if you are interested, you can remember the first the successful kidney transplant between identical twins that I shown. And next is the first human whole organ pancreas transplantation in 1966. Then the first Heart transplantation was done by Christian Bernard in 1967. Then cyclosporin was introduced in the 1970s at a 78. First successful heart-lung transplantation was later performed in 1981. Now the latest one is the description of laparoscopic living donor nephrectomy. So this is a late recent advances in the 1995. Now organ transplantation is well established and is an effective treatment for selected patients with end-stage organ failure. So the recipient is in an end-stage organ failure. So the various organs that we have transplanting successfully are the kidney, liver, pancreas, heart, lung with good outcome. However, transplantation of the small intestine is yet to be popularized. So before we go into the transplantation proper, just to have a basic idea about the various terms, the terminologies that we use. One is allograft, that is wherein an organ or a tissue is transplanted from one individual to another of the same species. And the allo antigen is the antigen that is found in the allograft. So that is the transplant antigen. And the antibody again is that antigen is allo antibodies. One important term is the human leukocyte antigen HLA, which is the main trigger to graft rejection, seen as a major histocompatibility complex. Next is a xenograft, that is a graft performed between two different species. So there is difference in species. One important terminology is orthotopic graft, wherein the graft, that is the donor organ, is placed in its normal anatomical site. Whereas a heterotropic graft is a graft placed in a site different from that where the organ is normally located. For example, the kidneys. Okay, so this is the basic definitions. If you have an idea, it is easy to understand. So, very idea of graft rejection, we normally follow allografts. So there is definitely a graft rejection. It is not a non-specific inflammatory response, but it is very much mediated by the T lymphocytes. There is an allelic differences at polymorphic genes that give rise to histocompatibility antigens, which are called the transplant antigens. And these transplant antigens are of two types. One is the ABO blood group antigens, and the next is human leukocyte antigen HLA. The ABO blood group antigens, as the name suggests, it is just not confined to the blood cells or the RBCs. There are other cells also that exhibit that contain these ABO blood group antigens. So we have to ensure that not just the blood matches, but also ensure that the recipients receive a graft that is ABO blood group compatible. Otherwise, there is a naturally occurring anti-A or anti-B antibodies in the recipients against the donor antigens. So there will be definitely a hyperacute or the very first rejection in transplantation. So this particular table you all know. So the donor, if he is O, so the recipient should be of the group O. It can be of any group O, A, B, or AB, because this donor group O does not have any antigens on it. Similarly, the donor group A should be giving to the recipient group A or AB. Likewise, B to B and B or AB. AB is supposed to donate only to AB recipient. Okay, so this you all know. This is just refreshing your memory. The basics of immunology is going to be discussed. I hope all that is already covered well and a strong foundation in your microbiology classes during your second year MBBS. Okay. So again, this is HLA antigens. Quick revision. So to remind you all, these HLA antigens are the most common cause of graft rejection. So what exactly are these HLA antigens? There are two different classes of antigens under the histocompatibility complexes, which are strong transplant antigens, just by virtue of their physiological role of antigen recognition units towards the T lymphocytes. So these antigens, these HLA complexes classes present as antigen recognition units for display of antigens from foreign pathogens to be recognized by the native T lymphocytes. They are highly polymorphic, and that is amino acid sequence differs widely between various individuals. So there is no the remote chances of individual uh, similarity, and that is how we have to trade that similarity for HLA matching, and hence go for transplantation. So this polymorphic nature has to be kept in mind to match HLA antigens during for transplantation. Now, as I said you, there are two classes of HLA antigens, one class 1 and class 2. The class 1 is present in all the nucleated cells in the body, whereas the HLA class 2 antigens are present on the antigen presenting cells, namely the dendritic cells, the macrophages, and the B lymphocytes. Okay. Out of these two classes, HLA class under HLA class 1, the HLA and B, and under class 2 HLA-DR are the most important in organ transplantation. So we have to look for these uh, particular groups under the specific under the varied classes for matching under HLA matching sequence. So how does this HLA antigens effectively perform rejection? So this antigens are expressed by the graft cells. Obviously, the donor graft cells, they activate the T lymphocytes and they stimulate the proliferation of the T cells in response to interleukin and T cell growth factors. Now, this activated CD4 T cells, the T lymphocytes, they release cytokines and other key members that play a central role in orchestrating the mechanisms of rejection. So that is the main idea. The HLA antigens activate the T lymphocytes through the interleukins and T cell growth factors, and this activated T lymphocytes, they release cytokines and other chemical mediators that ultimately result in antigen antibody reactions and hence graft rejection. So this is how the CD4 T cells are functional. The antigen presenting cells, they have the major histocompatibility complex, that is the HLA class 1 and class 2. In organ transplantation, HLA A, B, and D are classes. They activate the T lymphocytes, and through the release of interleukins 2, 4, interferon gamma, interleukin 4, and interleukin 5 also, they ultimately activate the natural killer cells, the TCP cells, and the B cells, cytotoxic precursor cells, and the T cell receptors, and they cause non-specific cytotoxicity or specific cytotoxicity when they are activating the precursor cells. Also endothelial activation and hence thrombosis, and delayed type of hypersensitivity uh, when the macrophage is activated. This is a macrophage. When it is activated, there is a delayed type of hypersensitivity leading to delayed or chronic rejections. And B cells, the plasma cells are activated, hence there is antibody formation against that particular HLA antigen. So this is how the mechanism of graft rejection occurs, by the activation of T cells and subsequent release of interleukins and interferon gamma. Okay, so this is just the basic ideas that you all have. So what are the types of graft rejection? So graft rejection is broadly classified under three categories, that is hyperacute rejection, acute rejection, and chronic rejection. So what is this hyperacute rejection? This is the most important immediate graft rejection that occurs because of the incompatible antigens, ABO antigens, or because of the presence of preformed anti-HLA antibodies in the donor, in the recipient. So the recipient has preformed antibodies. There is or there is presence of ABO incompatibility. Then there is this hyperacute rejection, which is characterized by, I said you, there is endothelial damage in such cases. The antibodies attached to the endothelium and there is damage, and hence there is intravascular thrombosis and definite hemorrhage. So there is interstitial hemorrhage. So this is the pathology in hyperacute rejection. This can be seen in kidney transplantations. Okay. Next is the acute rejection. This again, it is acute, that is because it is before the first 6 months post transplantation. This is again T cell dependent. It may be cell mediated or antibody mediated, or it may be both of them. But this step is reversible and it is within our hands. So for active active suppression of this acute rejection, you will have to give immunosuppressant agents. Proper immunosuppressive therapy will curb acute rejection in an organ transplant. This chronic rejection that occurs after the first 6 months of transplantation, and this is the most common cause of transplant failure. Here, the antibodies that are slowly formed, progressively formed, they play an important role. So, this chronic graft rejection it is characterized. It is maybe because of certain infections with cytomegaloviruses or poor immunosuppressive compliance. That is, the patient is not taking immunosuppressive therapy properly, or he was advised against. He was advised to stop the immunosuppressants. Then there is chances of chronic rejection. Also, when there is one particular term called cold ischemic time. When that is prolonged, then there are chances of chronic rejections after 6 months of transplantation. So what happens here is, I told you this is a non-immune factors that contribute to the pathogenesis of chronic rejection. Here there is myointimal proliferation in graft arteries. The grafted arteries that are there is myointimal proliferation, hence leading to cutting off, proliferation, there is thickness, and then there is reduced blood supply, hence ischemia, and subsequent fibrosis of the grafted organ. That is the donor organ, that is the grafted organ, gets fibrosed. Hence, there is failure of the graft or the transplantation. So, this is the basic types of the basic different types of graft rejections: hyperacute, acute, and chronic. Now, there is one more entity called graft versus host disease, wherein some of the donor organs, they have a large number of lymphocytes which react against the HLA antigens of the recipient. So it is graft versus the host. So the graft antigens, the donor antigens, they react against the HLA antigens of the recipient, hence leading to the graft versus host disease. This is a fatal, a fulminant type of graft rejection. It involves the skin and the skin most of the times, all of the times. It has a characteristic rash on the palms and soles. If it is a small bowel transplantation, then it will involve the liver also. And if it is a liver transplantation, the GIT is symptoms of GIT are to be manifested. It is a serious and fatal complication of organ transplantation, graft versus host disease. Hence, it is very important for us to match the antigens before transplantation as far as possible. Yeah, so the next topic is HLA matching. So these HLA molecules that are coded by the MHC complex that is situated on the short arm of chromosome 6. Now this expression is codominant, that is genes on both the maternal and the paternal chromosomes are all expressed. So two chromosomes on half of the haplotype of the maternal side. Subsequently, all the four haplotypes of maternal on the maternal and paternal side, hence they are all codominant, are all expressed. So an individual may express anywhere between 6 to 12 different types of HLA antigens of one specific group, depending on the degree of homozygosity. If it is homozygous, all homozygous will get as less as 6 antigens. If it is heterozygous on all the different loci, then you will get as high as 12 different antigens of one particular gene. Okay, so that is called codominant expression of HLA antigens. See, this is the HLA system on the short arm of chromosome 6. Group class 1 is under A, B, and C. Class 2 is genes coding are under DR, DQ, and DP. For us, in transplantation, A and B is important, and class 2 DR is important to be matched. This again, I told you about the inheritance of this HLA antigens. This haplotype is inherited from each parent. It is a complete haplotype. And depending upon the homozygosity, it is either, and it is there are codominant. So depending upon the homozygosity, the number of number of genetic HLA haplotypes that we derive depends. So one HLA haplotype depicted as A and D. This is A and D. One child shares one AC, AD, BC, and BD, depending upon the combinations. So the chances of two siblings sharing the same haplotype is 1 in 4, and the sharing one haplotype is 1 in 2. They will neither share the same HLA haplotype almost all of the times. Okay. A can be repeated one twice. Example. Similarly, uh, same parental haplotypes, that is A and B, this sharing can be as much as 1 in 4. Okay, so all this is not actually very important. Just remember that there is a huge um, pool of HLA antigens, just because the HLA antigens are codominantly inherited from the paternal and maternal haplotypes. So that is how we get a huge pool of HLA antigens. This is what I try to bring to your mind. Okay, so what the basics is, you should always try to match the donor and recipient HLA antigens as far as possible. The relevant antigens must be tried to match. That is done in tissue typing laboratories concurrent with organ procurement units and also the transplantation units. This is all a teamwork. The tissue typing laboratories work in conjunction with the organ procurement units and the transplantation units. So when you have adequately matched the relevant HLA antigens, then there is the need of intensive immunosuppression is reduced comparatively. Comparatively, you can try to reduce the immunosuppressive therapy a little bit. Also, the episodes of rejection post transplantation can be decreased. So I was always telling you about the immunosuppressive therapy. To have an idea of the immunosuppressive therapy, we'll just go back um to the basics of chemotherapeutic agents that you were taught in your pharmacology classes. So basically, for our organ transplantation, we have to suppress the activation of T lymphocytes and the proliferation and then the activation of T lymphocytes to prevent a graft rejection. Okay, so the range of different agents that are available act at different sites during T cell activation and proliferation for for an effective immunosuppressive outcome. So what are the various agents that are used? One is the calcineurin inhibitors, that is the cyclosporin and tacrolimus. Uh, the others are, I'll just name these agents in this slide. I'll tell you how they're acting, the stage at which they're acting subsequently. The others are anti-proliferative agents, that is, they inhibit the proliferation of T lymphocytes. That is azathioprine and mycophenolate. Mycophenolate, its components like MMF, that is mycophenolate mofetil and MPAS. Okay, just try to remember the names and the mode of action to have an idea of the mode of action. Steroids, glucocorticoids are potent immunosuppressive agents, the glucocorticoids specifically. Next, antibody therapies. They could be monoclonal antibodies or polyclonal. Monoclonal are more effective. They directed against the monoclonal antibodies directed against the interleukin 2 receptors on the T lymphocytes. And the polyclonal antibodies, they are on the thymocyte globulin. Anti-thymocyte globulin antibody is a specific example for polyclonal antibodies. The other group is the mammalian target of rapamycin inhibitors, also short termed as mTORs. Example are sirolimus and everolimus. So they are better than this calcineurin inhibitors, which are most commonly used, just because they inhibit one particular intracellular kinase and hence arrest the division of T cells, proliferation of T cells. Okay, so the principal mode of action is thioprins. They prevent the lymphocyte proliferation. This stage, this is the activation of T lymphocytes, CD4 T lymphocytes, and then their proliferation. So various stages at which the immunosuppressive agents act. This antibody therapy that we give, monoclonal antibodies or polyclonal antibodies, they act by depleting the antibodies and hence initially curtailing the rejection. So the antibodies formation is depleted, that is decreased, and hence there is curtailing of the rejection process. But subsequently they may also lead to causation of infections because of decreased antibody response in the human, in the donor patient, in the recipient patient. I'm sorry. Yeah, this anti-CD4 monoclonal antibodies again also act against these CD4 T lymphocytes and hence their activation. Next, calcineurin inhibitors, they block the interleukin 2 gene transcription. Okay, again that is the activation stage. Calcineurin inhibitors, they block the interleukin 2 gene transcription and hence the activation of T lymphocytes. mTOR inhibitors, they block the interleukin 2 receptor signal transduction and subsequent proliferation of the activated T lymphocytes. Okay, so these are said to be better than the calcineurin inhibitors, and hence they are of late recently being used in renal transplantation cases, because I told you in renal transplantation cases there are chances of hyperacute graft rejections are very common. Okay, so you should remember the potent side effects of each immunosuppressive agent. They're not See, azathioprine is bone marrow suppression, very important. Cyclosporin again is nephrotoxic. Cyclosporin and tacrolimus are nephrotoxic. mTOR inhibitors, they have this dyslipidemia and pneumonitis, thrombocytopenia. Immune reactions, infusion reaction, and autoimmune diseases will be common with the antibody therapies, that is monoclonal antibody therapies. So this is just a gist of what the side effects, possible most potent side effects of each immunosuppressive therapy agents. So what are the various immunosuppressive regimens that are to be used for a particular organ transplantation? Basically, it is the same for all organ transplantation. You have to suppress the host immunity. It is to maximize the graft protection with minimum side effects. Side effects to the recipient should be as low as possible. So most regimens are based on the calcineurin blockade only, and they also with or without the steroids and anti-proliferative agents. So this immunosuppressive therapy is maximum for up to about the first 3 months, and it may be indefinitely extended beyond the first 3 months post transplantation. That is under maintenance therapy. So, how long a particular patient has to be on immunosuppressive is tailor made for each patient and the organ that he receives. Okay. Now, immunosuppression always obviously will increase the chances of risk of infections and malignancies. So you should keep in mind the various uh, complications of the immunosuppressive therapy that you are giving to the recipient trans patient. So the first thing is infection, that is very common with immunosuppressive therapy. What are the various types of infections? Obviously, when there is decreased immunity of the host body, there's the high risk of opportunistic infection, especially the viruses and the fungal infections. So, how are these viral infections manifested? They are manifested as either pneumonia or gastrointestinal symptoms. And what are the various most important viral viruses that play a major role is the cytomegalovirus, or reactivation of the varicella zoster leading to herpes zoster. Usually, this is not seen in adults, but it may be seen. You have to have an idea. The reactivation of a latent virus. Okay. So, the risk of infection is again highest during the first 6 months. The fungal infections mainly are the pneumocystis jirovecii infections, or you may also find candidal or aspergillus infections. Okay, so that is the fungal infections. So, what you have to do is, if available, pre-transplant vaccination again is the community acquired infections should be considered if available. Next, the most important complication of an immunosuppressive agent is again malignancy. In children, they're very much at risk of developing PTLD, that is post-transplant lymphoproliferative disease. This is a vast disease complex that may involve any part of the body, from the central nervous system, which carries a poor prognosis, to the GIT or the skin or whatnot. So this is a highly uh, fatal complication, especially seen in children, the PTLD malignancies. Other common malignancies are the squamous cell cancers of the skin. So they may develop, so this recipient should be coming for a regular skin checkup. Okay. So this is a potent side effects of the immunosuppressive complications of immunosuppressive therapy in an organ transplanted host. So now coming to the main topic, organ donation. So we'll talk about the transplantation as primarily the organ donation. That is how the organ is procured and how is it transported and how is it surgically implanted in the host. So we've prepared both the donor and the recipient. With donor by matching, we should be doing it by matching the HLA antigens and ABU compatibility. Then we'll procure the organ from the donor. We will process the organ, and required storage has to be taken care of and transported to the recipient, to the host. Now the host is priorly prepared with the immunosuppressive therapy. So this is how you have to understand the organ transplantation procedure. So coming to organ donation, obviously the donors are of two types. That is the cadaveric donors or the deceased donors, that are dead donors, and the living donors. These living donors, they could be genetically related or genetically unrelated. Okay. First, coming to the living donors. You should always evaluate this living donors concept is quite fastly developing. You will have to, and it carries a less uh, complication rate. So you'll have to evaluate the donors on the physical, medical, and psychological grounds, and there should be no harm to the donor on a long-term basis. For example, in a renal transplantation case, the donor, living donor may develop hydrocele of the scrotum on the side of that on the side of that nephrectomy or transplanted kidney. So this kind of long-term complications have to be well taken care of. Now the mostly the procedures living donor organ procurement is mostly laparoscopically. Hence, there is less pain and less scarring and faster recovery. Both the donor and the recipient should understand the implications of the proposed operation, and that there should be no evidence of coercion or financial inducement. That is, the donor is not forced to donate his organ, mm, either by forcing or showing some bribery. That should not be there. That you should be compulsorily ensuring. Live donors of segments of pancreas, small bowel, and lung. These are also quite fastly developing of late. So the very first of living donor, live donor donation was kidney was first donated in 1954, as early as 1954, and adult liver was donated in 1997. So this is how we are advancing in live donation procedures. This deceased donor procedures was uh, quite known from the initial stages. Now, these deceased donors are of two types. They're either brain dead or cardiac death. So, brain dead donors or donation after brain death is called DBD. That is, these donors are considered dead, but the pumping heart continues to perfuse the other organs. So, they provide the major organs for organ transplantation. This pool of donation is maximum, wherein there is brainstem dead, that is, they are declared brain dead, but the heart beats. Initially, they were called beating heart donors. They were called beating heart donors. That is, the heart beats, the circulation is maintained until we procure the organs. That is, the surgical team comes to the area of, to the locality of that brain dead patient in the ICU, of course, in a hospital setting mostly, and then they procure the organs. So it is this kind of organ donation will give you the maximum majority of organs. This other group of cadaveric donation is donation after cardiac death. These are the elective donation of the organ. That is, the patient himself, before he goes into that certain coma, or the relatives of the patient when he is in the ICU, will give you consent for organ donation, uh, because there are slim chances of that patient's survival. So this is elective kind of donation. So they usually write down that they will donate the kidneys, livers, pancreas, lungs, and corneal transplantations. Okay. So this is donation after cardiac death. Now you have to understand what is brain death. So declaration of brain death is very critical, and it has its own legality in various countries. It results from a stroke or traumatic head injury wherein the brainstem stops functioning. And how is that known? That is permanent functional death of the brainstem, as loss of consciousness and loss of spontaneous respiration in the absence of a functional brainstem. So this is how a brain dead patient is defined, and he has to be declared dead by a team of doctors before there are any chances of organ donation. So what are the preconditions? He should have suffered major brain damage of some known etiology. Of the known etiology, there should be a brain damage, and the patient is deeply unconscious, and he definitely requires a ventilatory support, and without that support he is definitely dead. You should also rule out the action of a muscle relaxing agent or drugs with CNS depression. If they are administered, they have to be ruled out before declaring the patient to be brain dead. Other causes that contribute to central nervous system depression, like hypothermia, profound hypotension, and metabolic or hormonal conditions, they all have to be ruled out before declaring the patient brain dead. Now, how is that? How is he clinically assessed? He has to be assessed by a team of doctors, not less than 3 members. There is absence of cranial nerve reflexes, that is a pupillary and corneal and pharyngeal reflex. The caloric reflex also has to be absent, and the absence of motor response to a painful stimuli, and the absence of spontaneous respiration. How is that tested? This absence of spontaneous respiration is tested by initially giving 100% oxygen ventilation for 5 minutes. Then the patient is disconnected from the ventilator for 10 minutes. And then we have to look for the absence of spontaneous respiration from the patient's side. How is that seen? Biochemically, there is increased PCO2 level, and this increased PCO2 level should definitely stimulate the respiratory centers in the brainstem, right? So adequate levels of PCO2 should stimulate the brainstem, uh, indicating a hypoxic state in the body. So when there is, in spite of this stimulation, when there is no spontaneous respiration from the patient's end, that is how he is declared brain dead. That is the loss of absence of spontaneous respiration. But at the same time, we have to ensure that there should not be a hypoxia to the organs. That is, the perfusion to the organs should be maintained. So to prevent hypoxia during this apneic period, that is the 10 minutes testing time, oxygen is delivered via an endotracheal catheter. Okay. So these donors, cadaveric donors after cardiac death, that is DCD donors, they are grouped under 5 categories by the Massachusetts classification. The first category is they are dead on arrival at the hospital, that is dead at the time of hospitalization. Category 2 is the patient was resuscitated without success, that is resuscitation failure. Category 3 is they're awaiting cardiac arrest after withdrawal of support. So once the support is withdrawn, there is definite cardiac arrest. And category 4 is cardiac arrest while the patient is brain dead. Cardiac arrest and unsuccessful resuscitation in hospital is under category 5. So these 1, 2, and 5 categories are uncontrolled. That is, we never know when the patient was dead and the time of presentation. See, when he was brought dead to the hospital, or resuscitation, how long was it continued, and that time, there's a warm ischemic time, that is wherein he was diagnosed dead and we start procuring the organs. So that is the warm ischemic time. So this warm ischemic time is very important, and it is said to be high in these particular categories. So 1, 2, and 5 categories, this warm ischemic time plays a major role, and that is how these categories of patients, they give us a poor donor organ. Okay. 3 and 4 categories are control, that is you can control you can wait till the surgical team for organ procuring, that is removing out the donor organs. Surgical team arrives, so you can wait till that time, so they are controlled. This while the patient is brain dead, or you can voluntarily prolong for a little bit period of time the cardiac arrest by continuing ventilatory support. So these two categories, that is 3 and 4 categories, are controlled. Uh, I told you about this warm ischemic time. Ideally, it should be 45 minutes, but practically speaking, it can be as much as 2 to 3 hours. That is, from the time the patient was declared dead to the time the surgical team arrives to remove the organs from the donor. Okay, so that warm ischemic time can be practically as much as 3 hours. The maximum donor pool is from the category 3, that is where they are awaiting cardiac arrest after voluntary withdrawal of the support at the request of the relatives, of course. Now, how is this deceased donor also has to be evaluated? I told you the donor, the organ procurement team has to evaluate the deceased donors. That is, if it is an elective donation, they'll have to give us the list of the list of their comorbidities, or the health condition has to be registered in the registry, and hence helping the evaluation. Or if it is the other categories of donors, deceased donors, they have to be quickly evaluated before organ is removed for donation. So what do you have to look for that? If you look for in those such patients, such donors, is look for rule out any transmissible infectious agents. You should also rule out the presence of HIV or intravenous drug abuse. HIV can be HIV donor with the HIV can be, if needed, can be donated to the recipient who is also HIV patient. Okay, so that is a rare condition. You can have an exception then. Now, Creutzfeldt-Jakob disease is the absolute contraindication. You are not supposed to take out organs from such a patient. Hepatitis B, an active systemic sepsis, systemic infection. In our case, abdominal infections, if any, they are contraindicated in for donation. Malignancies, exception, all malignancies better not take out the organs, excepting some tumors of the central nervous system and non-melanotic tumors of the skin, carcinoma in situ of the uterine cervix. Such cancers, they can be considered, uh, they can be accepted for organ donation of organs other than the involved part. So obviously you're not supposed to uh, uh, transplant a uterine cervix with the carcinoma in situ, right? That is understood. So these cancers are exceptional. Otherwise, malignancy is also a contraindication for donation. Next, we have seen how the donors are selected, how the donors are prepared. Now, how do you recover the organs from either the live or dead donors? So what is the main aim? We have to preserve the functional integrity of the organs that have to be recovered, right? So the organs recovered, they have to be functioning to the maximum extent possible. Once they are brain dead, the deceased donors, once they are brain dead, there's definitely derangement in the fluid electrolyte balance, and hence hemodynamic stability is disturbed in the brain dead patients. So what is our aim? The organ recovery team, they have to be they have to carefully monitor and manage the fluid balance in the deceased donor from whom we are taking out the organs. So such patients, we will give them vasopressins to provide hemodynamic stability. Also, triiodothyronine can be given, inotropic supports are given. Next idea is the perfusion in situ. This very particular term is wherein we perfuse the organs when they are present in the donor itself, that is a deceased donor. So immediately we have to try to uh, cannulate the aorta as soon as possible to allow for perfusion in situ, hence proper integrity of the donor organ. So I told you the warm ischemic time should be ideally 45 minutes. This produces rapid cooling of this perfusion in situ, that will give out some perfusing agents. We inject them into the body, deceased body, so as the organs are well perfused, such that there is rapid cooling, and hence the metabolic activity in these organs is decreased, and then their viability is preserved. So this is the main idea in giving perfusion in situ. That is, as long as the organ is still in the within the body itself. So how is that done? There are some solutions. The heart is perfused with a cold cardioplegia solution. This is via the ascending aorta that goes to the heart. So the ascending aorta is cannulated here. If it is to be the lungs to be procured, then they are cannulated via the pulmonary artery, and this perfusion liquid solution is injected. For the abdominal organs, they are chilled organ preservation solution, that is via the abdominal aorta, or the portal vein. Mainly to the liver, it is the portal vein. They are cannulated. So this is how the organs are perfused in situ even before the dissection or the organs are removed from the body. So the next step would be you have to remove the organ from the donor body. If it is in the thorax, the order of removal of organs is first you have to remove the heart and then the lungs. So you have to ensure that the lungs are maintained perfused when the heart is removed. So that is how the most sensitive parts are first removed. All the organs are initially perfused. Then the most sensitive parts are first removed, and the parts that you feel that will be perfused for a longer time will be removed at a later time. Okay, in a sequence. If it is the abdominal organs, first the small intestines, they are highly vulnerable to ischemia with very narrow blood supply margin. After the small intestines, you have to remove the pancreas, then the livers, and kidneys are the last to be removed. Then samples for donor, after you remove all these organs, the samples of donor spleen and mesenteric lymph nodes are removed to confirm the tissue typing. I told you there is tissue typing laboratory also, the HLA. If it is an elective donor, definitely the HLA is matched. The HLA pool is generated. It is generated by a PCR based DNA and typing. So PCR based DNA typing helps in getting out the HLA antigen pool of any donor. If it is an elective donor, we definitely will be having that pool ready-made before itself. But if a deceased donor who, I told you of the categories 1, 3 and 5, for such patients, for such donors, we will remove tissues from the spleen and the mesenteric lymph nodes for to help cross matching. Okay. After these organs are removed, they are further flushed with a chilled preservation solution, and then they are ready for transportation. How are they transported? At 4 degrees centigrade, placed in ice in a double or triple sterile bags. So this is how they are transported. The organs are transported at 4 degrees centigrade. Uh, Static transportation was initially advocated, but now there is this machine transperfusion allowing for non-static transportation also. Okay. Next is, what are the organ preservation solutions that we usually give? Most important, what is its characteristic features? They should contain impermeants to limit cell swelling. That means they should be impermeable to the cell wall, and hence there should be no cell swell. They should limit the cell swelling, and they should also buffer the acidosis and electrolytes that are present within the organ. The composition reflects that of intracellular rather than extracellular fluid. Okay, these intracellular fluid compositions are better matched. The best example for organ preservation solution is the University of Wisconsin solution, most widely used. The other solutions are Eurocolins solution. Okay, so this is how the organ preservation solutions are used to flush, flush preserve the organs. So what is the maximum storage time? That is from the time the organ is removed to its transplantation. Safe maximum hours is up to 36 hours for kidney. Lung has to be immediately transplanted. It is as less as 8 hours. Optimal timings are better matched, better seen, but the safest maximum also can be kept in mind if there is distant transportation. Okay. So how these organs that are removed and transported, how far will they function in the recipient? That is to be determined to see the outcome of transplantation, obviously. So what are the factors? The donor factors like the age of the donor, or the presence of pre-existing damage in the transplanted organ. If there is any damage, then hemodynamic and metabolic stability, instability of the donor at the time of organ procurement, all this will decide the organ functioning after transplantation. The procurement related factors, wherein I told you the warm ischemic time, it has to be as less as possible, the type of preservation solution that you use, and the cold chain that you maintain, the cold ischemic time. In the recipient related factors, obviously the implantation techniques have to be carefully done to provide for maximum outcomes after transplantation. Again, the hemodynamic and metabolic stability, also the immunosuppression in the recipient to allow for maximum acceptability. Now, kidney, pancreas, or small bowel transplantation, immediate graft functioning is desirable but not vital. But in case you transplant, when you transplant a heart, lung, or liver, we have to resume these organs have to resume their functioning immediately after transplantation. If not, you'll have to immediately work up on the faulty methods, either in the implantation techniques or the immunosuppressive techniques. So heart, lung, and liver transplantation, they are desired to give maximum functioning immediately after transplantation. Okay, same thing that is again shown. The transplantation outcome, how is it given? It is described in the quality of life and the duration of life after transplantation, post transplantation. Usually live transplantation, it is a bit more at the end of 1 year and 5 years. uh, Good results are seen with uh, kidney and liver transplantation. A chronic rejection is one that plays a major role in all types of solid organ transplantation, graft failure. Again, there is the recurrence of the initial disease in the recipient that will invariably we will invariably lose the transplant. So now coming to the quickly we'll talk about individual transplantations. I told you I'll be talking about the renal transplantation and liver transplantation. So far I've given you the basics of organ transplantation. So any organ that they ask you, you can write the basics and you'll be getting adequate scoring. Okay. So coming to renal transplantation, it is nothing but the transplant of the organ transplant of kidney into a patient with end stage renal disease. So the patient is an end stage renal disease and he needs dialysis for continued renal function. So when you do a transplant, here you will give a better quality of life than when he is on dialysis. It releases the patient from the dietary and fluid restrictions of dialysis and the physical constraints imposed by the need of dialysis. Okay, it is more cost effective than dialysis and improves the patient survival provided there is a, a ready donor available. What are the indications? Obviously, end stage renal disease where the glomerular filtration rate is less than 15 ml per liter, or the other indications are hypertension, diabetes mellitus, that is the pancreas insufficiency along with the renal disease, that is the end organ disease in a diabetic patient, that is the kidney problem in a diabetic patient, and certain genetic diseases like polycystic kidney diseases, autoimmune conditions like the lupus, metabolic disorders, and chronic renal failure. Malignancies may also be considered are also considered for renal transplantation, provided they do not have distant metastasis. What are the contraindications? We are not supposed to transplant. Definitely, any donor, any recipient, host should not be having a cardiopulmonary insufficiency for any transplantation, be it liver or renal. There should not be cardiopulmonary insufficiency. There should not be hepatic diseases. He should not be using tobacco. If he is using, you have to stop tobacco usage for at least 6 months. And a morbid obese patient also has a high risk of graft failure. So you'll have to decrease the weight. He should not be having substance abuse and obviously no HIV infection. So preoperatively, you have to make the patient ABO compatible with the donor. The recipient should share as many as HLA antigens as possible with the donor. He has to be given immunosuppressants. Calcineurin inhibitors are most commonly used. Now we're also starting with mTOR inhibitors. Then also see for potential antibodies in the recipient. So this is a diseased donor kidney with multiple renal arteries and an aortic patch. There are multiple renal arteries taken on an aortic patch, and this aortic patch has to be shortened to limit the length of anastomosis. Okay, so this is just an example, a precaution to be taken. I'm trying to show you the picture. You take the renal arteries with an aortic patch for better implantation on the recipient aorta. If it is a donor, the deceased donor is greater than 70 years of age, it is not a contraindication for removing the organ, but then you have to take care to eliminate the part of aorta that has atherosclerosis. So the aorta shows severe atherosclerosis with extensive plaque formation and ulceration. So this is not suitable to use as an aortic patch. So then you will not take an aortic patch, and a lower polar artery has to be divided. Okay. So how do you implant? Yeah, this one important thing is in case of a kidney procurement, there is one very important technique wherein you cannulate the femoral artery and pass into the inferior femoral artery into the aorta, uh, and then you uh, infuse a double balloon catheter, introduce a double balloon catheter, and then you send the preservation fluid so that the kidney is immediately cooled. This is the last organ that has to be procured, I told you. So this has to be cooled to the maximum amount of time. So as soon as you get the patient, you will cannulate the femoral vein and artery, and uh, through that you enter the inferior vena cava and abdominal aorta, and then double balloon injection, a catheter, through that you inject the coolant or perfusing liquid. Okay, so this is important to decrease the warm ischemic time. This will decrease the warm ischemic time. Okay, non-heart beating donors, that is the cardiac death donors, 10 to 15 liters of chill preservation solution is administered. Live donor nephrectomy is undertaken either through a loin incision or laparoscopic approach. uh, Major complication rate after live donor nephrectomy is less than 5%. Always live donors, when properly matched, either whether they be related or non-related also, the complication rate is reduced in comparison to the deceased donors. So when there is hemorrhage, you'll have to give blood transfusion to rule out any intra-abdominal viscous damage. Also important is DVT prophylaxis. To DVT prophylaxis to prevent thrombosis and embolic phenomena. The after removal from the donor kidney, live donor, the kidney is flushed with chilled organ immediately on the back table and stored until it is transported to the recipient. Okay, so this is on the back table. The kidney is perfused. So surgery time is usually 3 hours. The donor kidney will be placed in the iliac fossa, the lower abdomen iliac fossa. And how is it done? The transplant kidney is placed in the iliac fossa in the retroperitoneal position, leaving the native kidneys in situ. The native kidneys are left in situ, and the donor kidneys or the transplant kidneys are placed in the iliac fossa. With the Foley's, initially you have to distend the bladder with saline with methylene blue to proper identify the bladder. This is just to doubly ensure that the bladder is well identified, and further the ureteric implantation is done. Okay, so what are the various steps? Firstly, in the I'm talking about the surgical steps in the recipient, in the host. So the retroperitoneal, you give an incision, a horizontal incision, you explore the muscles and push the peritoneum, you go retroperitoneally. Then the iliac vessels are dissected free so that they can be well controlled, within our control, and well clamped. So vascular clamps are applied on the iliac vessels retroperitoneally. Now first we'll do with the vascular anastomosis. The donor renal vein is anastomosed end to side to the external iliac vein in the recipient. And the donor renal artery, either on the aortic patch, it is anastomosed to the external iliac artery, or directly, when there is no aortic patch, it is directly anastomosed to the recipient internal iliac artery. Obviously, when there is short distance, you will go to the internal iliac artery. So that is how the vascular anastomosis is first done in kidney transplant. Then you will remove the vascular clamps on the retroperitoneal iliac vessels of the donor, so that now the kidney is well perfused. This uh, transplanted kidney is perfused. Next, we will do with the ureteric anastomosis. It is directly implanted into the dome of the bladder with a mucosa to mucosal anastomosis, followed by a tunneling of the muscular layer of the bladder. Okay, that is called the Lich-Grigor technique. Try to remember the name. Otherwise, you can just say that the ureteric anastomosis is done muscular mucosa to mucosa and the muscular tunneling. It could be muscular tunneling or a submucosal tunneling for ureteric implantation. Next important step is a DJ stent should be left in situ. This will reduce the risk of urinary leaks or early obstructions. Okay, so as usual, the DJ stent can be removed later by cystoscopy. Otherwise, this is a very important step wherein you can uh, rest assured of the urinary leak and also the early obstructions, if any thrombotic obstructions or the stricturous obstructions, all that can be ruled out with the help of a DJ stunt. Okay. Before closure, you'll have to ensure that the kidney is in a proper position and there is no kinking of the anastomosed vessels or the ureter. So this is how the kidney transplantation is done in the recipient. Okay, I hope I'm clear. First, the retroperitoneal vessels are clamped. Then the anastomosis, vascular anastomosis, first the vein is done and then the artery. Okay, this is how it's done. The renal artery on a Carrel's patch. So this is a Carrel's patch. The recipient, the donor kidney with the renal artery on an aortic patch is anastomosed to the external iliac artery in case of a deceased donor with a well with a good aortic patch that could be secured. Otherwise, then you'll have to go with the renal artery anastomosis to the proximal part of the internal iliac artery. The distal part is ligated. The proximal part is anastomosed to the renal artery end to end. Okay, end to end anastomosis. Next, the renal vein is anastomosed to the either to the external iliac vein or the internal iliac external iliac vein, or to the uh, usually higher above cases you can also anastomose to the inferior vena cava. Okay. Next, ureteric anastomosis. I told you it is a mucosa to mucosal anastomosis with a muscular tunneling. That is a part of the ureter. The donor ureter is tunneled on the muscularis layer of the urinary bladder, dome of the urinary bladder. Also, it could be a muscular tunnel or submucosal tunnel. If it is a submucosal tunnel, it is called the Leadbetter Politano method. Most commonly we use that they advocate is Lick-Rigor technique. Okay. So what are the complications once you have grafted the kidney? Initially, um, vascular complications like renal artery thrombosis is quite rare. More common is the renal vein thrombosis that occurs during the first week of transplantation, and how the patient presents with a sudden pain and swelling at the site of the transplant area. So this is again an emergency, an urgent surgical exploration has to be done, and the transplanted kidney has to be removed as early as possible. So in order to prevent this undesirable uh, outcome, we have to give the patient prior low dose heparin or aspirin prophylaxis to prevent these thrombotic phenomena. Okay. The other one is renal artery stenosis. It is a late complication as high as 10% in transplanted kidneys. How does the patient present? Increasing hypertension and decreasing renal function. The transplanted kidney fails to function to its initial normal limit. So how is that identified? Again, angiography can be done and see the ultrasonographically, or angiography can be done to see for the renal artery stenosis. So it can be easily managed with an angioplasty. When that fails, then you have to go for an open procedure and vascular reconstruction. Okay, this is the vascular complications. Coming to the urological complications, they account to up to 5% in transplanted kidneys. So, what are the most common complications? Urinary leaks. So, how is that done? How is that causing that done? Because there are technical errors at the ureteric anastomosis, or there is ureteric ischemia. That all these are technical problems. So, how does the patient present? Discomfort and urine leak from the wound site. So, that is indicated. That indicates urinary leaks. How is that treated? Reimplantation of the ureter into the bladder, or anastomose the transplant ureter to the same site native kidney. I told you that native kidneys are not removed in a transplanted individual. So to that native kidney ureter, you have to um, anastomose the transplanted ureter, so that there is normal drainage, there is anatomical drainage through the normal ureter, that is the body's original ureters. This is how you will correct the urinary leaks. Once there is obstruction of the transplanted ureter, that is also one of the complications. It could be either because of external pressure or because of a stricture. Pressure with a hematoma or a lymphocele. Lymphocyte formation at the site of the transplanted kidney is quite common, but usually it does not. It should not land up into such complications of obstructing the transplanted ureter. But if it does, then we'll have to intervene. How does that present? Since there is obstruction, the transplanted kidney goes into deteriorated functioning and hydronephrosis. So, and there is ureteric dilatation. So, how is that corrected? You go with the percutaneous anti-grade nephrostomy and insert a stent. Okay, or if there is a stricture, then go with the balloon dilatation. Of all these fail, this minimal invasive techniques fail, then you have to definitely go for surgical intervention by reimplantation, that is redoing the procedure if possible. Okay, so this is how it is corrected. What are the features of graft dysfunction? Early, the failure of grafted kidney. Early, it is because of primary non-functioning. That is, the kidney that you have transplanted, we have taken all pains in transplanting this kidney. Ultimately, it is non-functional because of the irreversible ischemic damage that inevitably occurred during organ procurement and organ transportation. So that is primarily non-functioning, then we definitely have to, that is a failed procedure. Delayed functioning, it is usually reversible ischemic injury, uh, necessitating the need for dialysis for a short term after transplantation. So this is reversible. You can always intervene. I told you the causes of such reversible injuries. Next, more important, most common is the hyperacute graft rejections. We have to take care with proper immunosuppression, arterial venous thrombosis of the graft vessels, drug toxicity, mainly when we give the CNI toxicity that we give, immunosuppression that we give, that also leads to toxicity and hence rejection. Infection, mainly cytomegalovirus in the graft, and mechanical obstruction. Sorry, this is not common bile duct, ureter here. Okay, so these are the early causes of graft dysfunctioning, which sometimes are reversible. But late causes of graft rejection, that is beyond 1 month, it could be chronic rejection or arterial stenosis and recurrence of the original disease in the graft, that is the end-stage renal disease such as glomerulonephritis, then mechanical obstruction. All these are causes for late graft dysfunction. What is the prognosis? Patient survival. It is prognosis is defined as patient survival and graft survival. So patient survival is as good as 95% provided the technique is completely foolproof and successful. 95% in 1 year, up to 85% in 5 years period. But graft survival depending on whether it is the live donor graft or deceased donor. So it is a little bit less in deceased donor. Live donor half life is better. Grafts obtained from live living donors is substantially longer than that of the deceased donor grafts. Okay, so this is about the renal transplantation. Okay, coming to liver transplantation, a brief history. Initial research programs on liver transplantation started in as early as 1958. I told you the first liver transplantation was done by Stars uh, after the introduction of cyclosporin and the University of Wisconsin solution. We started getting improved organ preservation and hence organ procurement, and finally, deceased donor transplantation, liver transplantation also was becoming successful. First living donor liver transplantation was done in 1999. Okay, what are the indications when the patient has cirrhosis? The causes of cirrhosis being alcoholic liver disease, viral cirrhosis, or non-alcoholic steatohepatitis, primary biliary cirrhosis, and sclerosing cholangitis. Now, how do you grade and how do you type the patient? That is all different. MELD scores, child scoring, all that is done uh, before the patient is deemed fit for transplantation. Okay, 10% of cases will have acute fulminant liver failure, either viral or drug induced. Drugs most commonly is the paracetamol in India. In our country, paracetamol overdose will cause drug induced fulminant liver failure. Such patients are potential candidates for liver transplantation. Also, certain metabolic diseases like the Wilson's disease, oxalosis, and familial amyloid polyneuropathy. These are all the indications for metabolic liver failure and primary hepatic malignancy. HCP-related cirrhosis. This is hemochromatosis cirrhosis, cirrhotic liver. All these are diseased livers and potential candidates. The entire liver is involved, and these are candidates for liver transplantation. How is the donor selected? It is either cadaveric or living donor. The blood group HLA, ABO, and HLA have to be matched. Sometimes HLA need not be matched if it is an emergency case. That's all. Otherwise, try to match the HLA antigens always. Size matching is important. Marginal donors may be considered. Always standard donors are to be taken into consideration, but in certain cases of liver transplantation, even marginal donors can be considered. There is this concept of split liver grafting, which is very important, wherein the donor liver is divided into right and left half. The deceased, if it is a deceased donor liver, then it is divided into right and left half, and the left half is given to child with a need for transplantation. In children with child C classification and certain metabolic disorders, or in adults, the right half of the liver is transplanted. So this split liver transplantation is a very important technology that they have developed, that helps both the adult and child uh, recipients at the same time with one single donor liver. Okay, this is the picture of a live liver donor. Now, how I told you this, how is this split done? It is according to the coordinate segments, such that the left lateral segment, that is 2 and 3, are transplanted into a child, and the right lobe all together with segment 6 also can be transplanted into an adult. Okay, so this is how the split liver grafting technique helps two patients with one donor kidney. Okay, so this is important. Next, cadaveric donor liver after back table preparation. That is, the perfused liver was well prepared. This shows the hepatic hilum. the portal vein, the hepatic vein, and the hepatic artery. Okay. Now, this that was about the cadaveric donation. For a living donor liver transplantation, it is usually it is usually reserved when there is long waiting period of cadaveric transplantation or a medical urgency. So these are two conditions where you will go for living donor liver transplantation, LDLT. Okay, provided the volunteer accepts. So if waiting is not possible, that is an emergency case, or the waiting is getting too long. Okay. In India, only the related and the approved donors by the ethical committee are allowed to donate. This is advantageous, such that it is an elective surgery, and the donor is known to be healthy, whereas in a deceased donor, we never know about the condition of the patient. And we can also reduce the cold ischemic times. Cold ischemia time, that is the storage time and the transportation time, can be reduced since it is an elective procedure. And obviously the waiting time. But the disadvantage is there is risk to the donor also, risk of surgery to the donor, and cost and resources. Here there is higher risk of biliary and vascular complications even in the donor. Okay, so this is the potential complication in a live liver donation. So what is the ideal amount of liver that we need? Minimum amount. The liver accounts for nearly 2% of the body weight. So optimally, greater than 1% of the liver weight or of the liver weight to body weight ratio is sufficient for a functioning liver. So minimum of greater than 1% liver weight to body weight ratio is needed. That is, a 70 kg recipient will need at least 700 grams of liver. Okay, minimum amount is 700 grams. So it should not go below 0.8 percentage. Okay, so this is the minimum amount of liver that can be um, transplanted for normal functioning. Now this liver live donation in a live donor, there are certain risks of death, major complications. I told you biliary complications, um, higher instance of biliary problems and vascular complications. Small for size syndrome may be present, and ethical issues. For adult to adult liver donation, I told you, this is a split liver technique that is followed. QSA is one instrument that is used. It's just like a harmonic that is used to cut the liver with better hemostasis. It is used to divide the liver into right and left lobes, so that the right lobe has to be transplanted into the adult recipient. The right lobe has to be transplanted, and such that the right lobe should definitely be having adequate hepatic functioning. So what is the technique? This is the incision uh, in the recipient. A transverse abdominal incision is given with a midline extension up to the xiphus sternum. This is the incision that is given for uh, liver transplantation. Firstly, you have to remove the deceased part of the deceased liver in the host. So you have to divide the common bile duct and hepatic artery first. Then the IVC is clamped and divided above and below the liver, such that there is enough stumps left behind for anastomosis. So once you remove this deceased part, the IVC stump has to be supra and infradiaphragmatic, has to be sufficiently sufficient stump has to be available to allow for proper anastomosis with the donor liver. Then third in line is the portal vein is clamped and divided. So IVC and portal vein are carefully clamped and divided. Okay. Next we have now we have removed the host diseased liver. Then we should maintain a veno-venous bypass. Before we introduce the donor liver, we'll have to maintain a bypass circuit that delivers the blood from the inferior vena cava and or the portal vein and back to the heart via cannula inserted into the internal jugular vein of the patient, such that till the time we bring in this donor liver, there is this circuit maintained. the heart and liver circuit is maintained. So we know venous circuit should be maintained. This is achieved by cannulating the internal jugular vein in the recipient. So this will give you the adequate time for proper anastomosis of the donor liver, of the transplant liver. So what do? The supra and infrahepatic IVC anastomosis is first done. Okay, first the IVC anastomosis is done, then the portal vein, and then the hepatic artery. So this is the order. First you divide the bile duct. Initially, while removing the kidney, the diseased liver, will remove the bile duct, common bile. Will cut the common bile duct first, then the hepatic artery, then the IVC, and lastly the portal vein. But when you anastomose, do it in the reverse fashion. That is, firstly the IVC is anastomosed, both the supra and infrahepatic parts of the IVC is anastomosed, then the portal vein and hepatic artery are anastomosed. Okay. So once all this venous or the vascular anastomosis is done, then we'll allow for reperfusion of the graft with the donor, or with the, sorry, with the recipient's blood. Okay. So that is how we will wean off this veno-venous bypass circuit. We will wean off this circuit and allow for the graft perfusion. So once there is blood flow through the through the transplanted liver, it is well perfused. We ensure well perfusion. Then we'll go for biliary drain. That is biliary connection. That is bile duct, common bile duct to duct anastomosis, without the use of a T tube. Usually we do not use a T tube. Direct anastomosis, duct to duct anastomosis, end to end is done. Okay. So this is the steps in performing surgical technique of performing the liver transplantation in the host. Okay, this is a surgical technique. I hope I'm clear. So after completed transplantation, the anastomosis in the order of performance are first the suprahepatic and next the infrahepatic inferior vena cava. First the suprahepatic, then the inferior infrahepatic, then comes the portal vein, um, then comes the portal vein. After that, the hepatic artery, and finally, the bile duct, duct to duct anastomosis is done. So this is completed liver transplantation. There are two techniques wherein there is this classical technique or the cable replacement. That is, you remove the entire diseased liver and you bring in the new liver, the transplanted liver, and you anastomose at the vena cava, both above and below the liver. This is the classical technique most widely used. But of late, we're also starting with this alternative caval preservation technique that allows the recipient liver to be removed without cross clamping the vena cava. That is, the vena cava is not clamped. See, here it was clamped and divided, right, above and below the liver. This this step is avoided and it is preserved. The inferior vena cava, that is just this donor liver, is implanted using a piggyback technique onto the recipient hepatic veins, onto the hepatic veins. It is directly onto the hepatic veins and not onto the IVC. That is, here the IVC is preserved, well preserved, without much intervention. Okay, so this is onto the hepatic vein. This transplanted liver is placed. This is called a piggyback technique. This is also coming into vogue right now, coming into use right now. These are the clinical pictures, intraoperative pictures. After full perfusion, after the completion of implantation or the transplantation, this you can see it is well perfused. The liver is seen well perfused. That is a successful transplantation. There are certain technical complications also. So what are those complications? First and foremost is hemorrhage. Hemorrhage has to be controlled. It is either procedural complication or inadequate preparation with anticoagulants. Okay, so that proper measures will alleviate the complication of hemorrhage. Next is vascular. It could be hepatic artery thrombosis or portal vein thrombosis. That is in the order of occurrence. Next, finally, is biliary. It could be because of leaks and stenosis. All these are technical complications depending on the procedure or the anastomosis success rate. So, certain other complications Early complications are infections, initially early infections, rejection, surgical or wound complications, biliary problems, vascular complications, and recurrence of the initial disease in the host. All these are early complications. Okay, these are all self-explanatory. Late complications may also occur as late as after 1 year post-transplantation because of the medication adverse effects. And I told you chronic rejection, it plays a major role in cases of late complications, again late infections and metabolic problems. Okay. So what are the various infections after the transplant? It could be nosocomial infections, opportunistic infections, or community acquired infections. In the first month, it is nosocomial pathogens like MRSA, gram-negative bacilli, candidal infections, and Clostridium difficile. In 2 to 6 months of post-transplantation, opportunistic infections with toxoplasma, pneumocystis carinii, fungi, and listeria. Also, reactivation of latent viral infections. And after 6 months, it is community acquired, either bacterial, viral, or mycobacterial. Okay, this is just an idea of the various infections in a transplant or in just liver transplantation itself. So, what is the prognosis? Liver transplantation should be performed at the time point when the patient is expected to have a better survival rate than without a liver transplant. Okay, so without a liver transplant, if he is having if he is having if you expect a better survival rate, then that patient is a better candidate for liver transplantation. Child C cirrhosis, survival of patient at the end of 1 year is up to 20 to 30, increase up to 20 to 30%. It is less than 5% at the end of 5 years. Survival rate after transplantation um, is 80 to 85 to 90% at the end of 1 year, 70 years in the other categories. But by the time the patient has evidence of child C cirrhosis, the patient may not survive long enough to get a transplant most of the times. So the outcome of liver transplantation depends basically on the what is the underlying disease in the recipient host liver, and the best results are seen when the patient has just chronic liver disease. Okay. Now a small idea on the future prospects. We are getting into better immunosuppressive agents. Also, non-invasive biomarkers for early diagnosis of graft rejection are coming into studies. Donor specific immunological tolerance, this is also one specific field that they are making studies into. Xenotransplantation and better outcomes with less graft rejections. This is our aim. I don't know how far we're going to achieve this aim. One important, potent, and very promising field is the stem cell technology and tissue engineering. So all these might help with improved results post transplantation. Okay. So this is about the transplantation class that you had all asked about. I hope I had given you the basic information, and if asked about the liver and kidney transplantation, I believe you are now well informed. So any doubts so far? Maybe I was a bit fast, but then I think I have been clear enough also. So you may ask me any doubts in the topic so far covered. So this transplantation topic is a quite hi-fi topic for you people. I tried to explain it in the easiest manner possible. You can always ask me doubts anytime, even after the class. Please go back and read the textbook. The maximum information I've taken out from our Bible, that is the Bailey and Love textbook. So you can always refer that textbook, and even if you have doubts later on, you can come and ask me. Okay. So I hope I have helped you with this topic. I don't know how far you will be asked questions in this topic, but now that the class is done, you must be able to answer. Okay. So if there's nobody coming up with their doubts or questions, I can call off the class. Okay. Thank you. Thank you for your time.